data set that the state provides us on a regular basis. I wanted to spend the last couple minutes on this slide talking about other fees. On the island, there's a opioid effort going on, and especially on the south shore of the island, there's a opioid issue, epidemic issues on the island. So for our PPS, we have bring in the naloxone data from the two hospitals, FDNY and NYPD, to track what are the naloxone distribution on the island and what are the naloxone safes on the island. We are also tracking the overall death rate related to opioid use. And then we're also bringing the EMS calls, looking at the call log, who had called and related to substance abuse and or it's not medically related. Bringing these two sources together, we created a community-wide portal called Drug Prevention Portal. For the people who are interested, you can log into our portal. It's called siprevention.drugprevention.org. Once you log in, you could see that there are interactive dashboards that's utilizing these three sources that I just mentioned to track the opioid trend line by month and to monitor real time what are the opioid usage in your neighborhood. And this is public facing website. And there's also a tab that is self-reported naloxone safe. So we are able to track in a near real time and to really understand what is happening out there in the community. Next slide, please. I wanted to echo what Raj had mentioned in the previous presentation, the importance of EMPI. Our PPS is dealing with more than 15 different EMRs from our 70+ providers. Working with Spectrumetics and utilizing their EMPI is crucial for us to be able to turn the analytics and generate meaningful report and hand it back to the provider's hand very quickly. Next slide, please. In the middle of the section is the analytics engine and how we integrate different applications. For example, the E360 framework that's focusing on the quality measures. There are about 50 quality metrics that our PPS is focusing on, and that is tied to our payments. Leveraging the EMPI I talked about in the previous slide, this is critical that we are able to generate provider-specific portal, and it is self-service. The executive or project lead at each one of the partners, they are able to log into the website, looking at the measure and bring the results back, for example, to one of their quality monthly committees for review of their results. On the very right-hand side, the output or the product that we're able to leverage the platform that Spectrumetics help us prepared. We can create disease-specific registries. We are able to do dashboarding of top health analytics on the various data sources that we have prepared in the EDW end. And finally, we are able to measure the partner's performance improvement, whether they are trending on the right direction or there are areas that we have opportunity to get better. Thank you.
Thank you very much, Jen. So we're going to pause briefly for a second poll question. What is your most pressing need for Medicaid transformation program implementation? Again, I'm going to launch the poll and give everyone about 45 seconds to answer. Okay, thank you, everyone. I'm going to close the poll and share the results. So 55% of people who answered selected data aggregation from disparate sources into a data warehouse. That was the highest selected, followed by 27% measures, calculation, and reporting, and then finally 18% for risk stratification of chronic disease and behavioral health members. Without further ado, I'm going to turn the presentation over to Dr. Volpe.
Thanks, Nathan. Next slide. So in reviewing the survey results, I see that the audience has a lot of similarities with what we're doing here in New York and certainly in the PPS. The need to aggregate information from disparate sources was one of our first goals, and we've been very fortunate to partner with Spectrumetics to serve as a data warehouse to pull all these different sources together, which at first blush would have seemed very difficult to do. As far as priorities, I have to agree that integrating behavioral health and primary care is probably one of the most important things we can do, in addition to maybe more globally addressing the social determinants of health, because without addressing behavioral health issues, we can never really get to the medical problem. And then, not surprisingly, a lot of our high-risk patients, a significant proportion of them, do have behavioral health or substance use disorders. So when you look at the slide, it kind of brings it all to a head. We looked at our top 500 high-risk patients, and you notice that they only represent about 1% of our 130,000 lives. If you look over to the right one notch, you'll see 100% of them have one or more chronic conditions, which is, again, not uncommon in the New York City market. There's obviously a lot of hypertension, cardiovascular disease, and diabetes. This population, this top 500, surprisingly represents 20% of preventable emergency room visits, and in one particular case represents, at the lower left-hand corner, 140 visits for one individual. Not surprisingly, if they're going to use the emergency room, they are probably also responsible for a lot of the readmissions because they're not getting adequate primary care and not getting adequate follow-up care. On the far right, you see 4 blue boxes, and again, we're looking at the breakdown between this top 500, and the 44% are involved in our Health Home or Health Home at Risk project. 12% are involved in our coordination of care. 47%, remember I told you that was a very important issue to address, have behavioral health issues. And 22% took our PAMP survey. Now, if you look in the lower right-hand side, you see that these individuals account for 3 times the spending of non-superutilizers. And again, that delta, if addressed, can redistribute money to provide better care for all. Next slide. As Annie pointed out, in addition to being able to aggregate information, it's important to be able to cut and slice it and share it in a format that's easy to use. So this was one of our first templates that we put out, and as you can see on the left-hand side, it just gives some basic demographics about the patient, so they're easy to identify. And on the right-hand side, the larger rectangle represents the so-called gaps in care, a percentage of the patient who did not get their hemoglobin A1C done, the patient who did not get cardiovascular testing when they're on schizophrenic meds. So we wanted to put it in a format, at least in the spreadsheet, that would be easy for them to see and easy to address. So what we do is we send this out to the providers, and then they send back to us what they've done to try to address this problem on an individual patient level. Next slide. Well, it's nice to be able to aggregate data. It's nice to be able to dice and slice it, but in the end, do you make a difference with this? And we were very proud to see, and I guess it's one of the reasons why we placed in the top, was that for those in the health home at risk, there was a 55% reduction in emergency room use. And for those patients who are under a diabetes management program, a 42% reduction in ER use. And for those patients in Project 3AI, which is the integration of primary care and behavioral health, we saw a 32% reduction. And lastly, on the community-based withdrawal program, which we're very happy is turning out to be very successful, we've seen a 33% reduction. So again, what this means to us is that if we bring the services to the patients that are needed, they do not go to the emergency room, and they do not get admitted and do not get readmitted. Next slide. So here's a little bit more current information. You know, we saw a big drop in the beginning of the first year, and now we're looking at the changes per 100 members in DY2. So you'll see that the drops now go from 30 per 100 down to 27 on preventable ER visits, 90 to 84%. So that's a pretty big drop. And then on the readmission side, we've seen a 10% reduction. So there was a big drop in the beginning, and we continue to see a drop as we move the program along. Next slide, please. So you saw the first slide, which had a simple spreadsheet of patient demographics on the left and gaps on the right. And this is the type of reporting that we can get from Spectrumetics in a different format, in the dashboard format, which makes it very easy for the provider to see the patient's demographics on the left-hand side, and again now look at the gaps in care or what was their latest BMI. So based on what their BMI, if we're working on obesity, we want to get that BMI down. We want to get those hemoglobin A1Cs down. And what's really important here is we got the HCC risk scores. So we provide the providers not only with clinical information, but a nice aggregate score to help have a sense of really what is the burden of disease in this particular individual. You look down and you'll see the analytics engine that will identify the gaps in care for the individual patient, whether it has to do with hemoglobin A1C or diabetic foot and eye exams. Next slide. One of the benefits of setting up a good foundation with data aggregation is that then you can cut and slice it and represent it in as many different ways as you want. So in this particular slide, we're looking at gaps by partner. And not surprisingly, some practices or some groups might be better at addressing certain gaps than others. And it helps us help them identify where their quote unquote deficiencies may be and help them to direct resources to address things. So for argument's sake, CBP would be controlling blood pressure, FVA is flu shots. So for those practices in general, you can see most of them do really well, but partner number 4 is at 43.6%. They need to institute a more aggressive flu vaccine program. Next slide. And drilling down now, we saw gaps across different providers, and now we're looking right down on a member level, and we're looking across, as we said, controlling blood pressure, CBT, and gap in flu vaccine, FVA. So it makes it very easy for the patients who are being cared by practices, some of whom are not that adept at doing their own registry reports with their own EHRs. Here's a dashboard that cuts across all plans, all patients, It makes it easy for them to address what needs to be done. Next slide. One of Dr. Chen's claim to fame is her geo-mapping. No visitor who's come to our center has not walked away very impressed with the ability to actually look across our beautiful triangular island and see at a glance, literally a glance, what is going on with any particular item. So we're looking here for opioid addiction. So opioids, across the island, you see a large concentration at the lower left, the 10307 zip code. It's one of our more affluent zip codes. And then you see up at the 10301. But in between, there's a spread. So there are two major concentrations, but it does cut across the island. But then when you're looking at what countries people come from and eventually what languages people speak, it permits us to provide culturally coherent care to people. So we can come to people and speak to them in a sense that resonates with where they come from or what they're used to hearing. So it's not one size fits all. We really try to personalize the care, and you can't personalize care unless you know more about the patient's language and ethnicity. Next slide. Here we go with diabetes and languages. Again, how can you provide diabetic education if you can't speak in the language of the patient? So we have language translation education services that we provide for all our partners to bring those staff members who are fluent in a given language the background that they need to use medical terminology to assist the healthcare provider, to assist the patient to get the care that they need and help themselves. This is a two-way street. It's not just dictation from a physician, nurse practitioner, PA down to the patient, but it's the patient communicating back, identifying what his or her barriers are, and giving feedback on what works and what doesn't. So this is a beautiful slide. It gives you a breakdown across zip codes on the left-hand side, also gives us a breakdown of countries in different colors, and it's mapped against, because this is a very, very intense slide with the amount of information you can access from it, where the hospitals are, where the SNFs are, where the behavioral health. So in this graphic, Dr. Chen has given us multiple different views on a given patient in a format that's easy to digest. Next slide. More geo-mapping across 4 different domains, if you like: behavioral health, hypertension, opioid, and alcohol. And you'll see on the upper left-hand side, behavioral health, very intense concentration, probably at the 10301 zip code. It's sort of a brownish red, but it also goes and shows you, if you zoomed in on it, what healthcare providers are in that location. So if there's a deficiency, it can help us relocate or teach people where they need to go to provide the services that have to be needed. Because another thing that we learned is it's not just if you build it, they will come. Quite frankly, if you build it, they might come. In some cases, you have to go to where the patient is, and that might be a homeless shelter, that might be a NYCHA building, which is in New York City Housing Authority. Wherever they are, sometimes we have to go to them. And you wouldn't know where to focus those resources without a geo-mapping tool. When you look at hypertension in the upper right-hand corner, you can also map against what they call food deserts. So there may very well be hypertension in that area because, quite frankly, there aren't enough fresh fruits and vegetables for people to eat. So if we know that there are food deserts concurrent with the hypertension, not only will the physicians be providing medications, but maybe on a healthier long-term basis, maybe we could encourage better distribution of food. And actually, quite frankly, we do have a deal with City Harvest, which has several very, 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 very large trucks that park in large areas in public housing, and we provide a prescription for food. So patients can go there with a little piece of paper and they get a bag of food. And what's also interesting is they have people who will teach you how to prepare the food. So if you're a Sicilian grandma like my mom was, she may not know how to cook food from the Caribbean, but she'd be more than happy to learn. If someone would show her, they'll show her how to do this. Lower right-hand side, you see alcohol. Again, super high concentration in that 10301 zip code. That's where the resources have to be for alcohol detox. And in the left-hand side, you'll see that opioids, again, concentrated in the lower left, 10307, I believe, but pretty reasonably distributed along that southeast border of the island, I guess, as opposed to the center. Next slide. Raj, I think this is yours.
Yes, Al. Thank you. Thank you very much. So this talks about the HCC model. We used that. There was in the survey, a significant number of you said that risk stratification of high-risk patients is important. So this shows our HCC model that we've taken the CMS HCC model and enhanced it greatly with clinical data, with behavioral health data, and some social determinants of health data elements. And the model we built was in 2014, and it was built in 2014 and 2015 data, and was used to predict expenses for 2016, expenses and ED visits. So the Spectromedics model performed significantly better in the very high-risk populations to what the claimed amount was. So it detected 19% better than the HCC model. And then average number of ED visits in our model were higher as well for the very high-risk population by 56%, and the average inpatient admissions by 47%. And same with the high-risk population as well. There was significant improvement with the HCC model by enhancing it with clinical data and behavioral health data. And again, on the same theme of talking about risk stratification, in one of the dashboards, you may have seen the various sample disease registries that were there on the right side, but we have disease registries in a number of conditions. And you could also drill down by 2 or 3 conditions. So one of the areas that a number of our PPS clients are looking at is flu shots plus diabetes plus hypertension at this time of the year. And it could be other registries as well. And we use, for the risk stratification, obviously, we use a predictive model. And now I want to, we have about 5 minutes left or 7 minutes left. I want to wrap this up and leave some time for questions. Our key differentiators is, first is our partnership with the 4PPS. 4PPS is in New York State. As you can see, we've learned immensely from Staten Island PPS. We've been working with them for close to 2 years now. And we hope that we've contributed a lot and also learned a lot from them. And then we are our security books were approved by the New York State DOH, so we're an approved, secure downstream partner, and we're hosted in Microsoft Azure. And then our ability to what's called chase lists, but our ability to identify the top 500, top 1,000 patients based on their risk profile, based on their gaps in care, and based on their gaps in measures. So that becomes very important. Gaps in measures, if by patient, by provider, that helps you then address those gaps, and that then helps in value-based care payments. And obviously, the risks also helps in readmissions, reducing admissions to the hospital as well. And I already mentioned disrupt capabilities. Also wanted to touch on the concept of proxy measures. The proxy measures are where we use, if, for example, there's a HEDIS measure that leverages claims data, and we want to calculate them in more real time, as opposed to when we get the adjudicated claims back, we can leverage clinical data, and that we create proxy measures for that. Strong capabilities around master data management and EMPI. our EMPI. Today there's an ONC challenge going on. We're in the top 10 in the nation for our EMPI within that challenge today, as of today. And then also our ability to integrate with RIOs as well. Thank you for your time. And if you have any questions, you feel free to reach out to Jeannie Schatt, who's been in touch with most of you. We do have a couple of questions. So Nathan, I'm going to let you ask questions.
Okay, thank you, Dr. Lockenpaul. So I know we're about at the hour. We've had a number of questions come in. We'll address a couple of them. And if anyone has any after the webinar is over, feel free to reach out. Okay. Question here. Where does EHR fit in here? Are electronic health records part of data?
Ani, would you like to take that question, or do you want me to take that?
Sure. So from our two leading hospitals, the EHR that we do file extracts on a nightly basis into the data warehouse. For the FQHCs, we also do file extracts. So Spectrumetics team provide us a data dictionary. We are able to map the data elements that is required to calculate the quality measures, and we go back to the EHR and map these elements and do the extraction from the EHR directly.
Thank you, Dr. Chen. We'll do one more. How is the provider attribution of measures determined? Is it based on client enrollee assignment?
Ani, would you like to take that too?
Sure. At New York State, there is a royalty algorithm that the state utilizes to assign patient or attributed members to a particular provider. The category could be by nursing home, by the PCP assignment, and or by certain chronic condition disease categories.
Okay, thank you, Dr. Chen. So we are at the hour. Again, if you have any questions, please feel free to reach out to us directly at the information on the screen, Jeannie Schatt. I'd like to thank our panelists today, Dr. Volpe, Dr. Chen, Dr. Lockenpaul, for a great presentation, and we hope everyone has a great rest of the day. Take care.
Thank you. Have a great day.
Thank you, everyone. Have a great day. Thank you.
Thank you.